A 72-year-old elderly lady with hypertension and diabetes mellitus comorbidities presented with history of ingestion of a foreign body, that is a mango seed, with dysphagia since 4 days. CT neck showed a foreign body obstructing the mid esophageal level with luminal narrowing. An endoscopy was done, and the endoscope has advanced into the esophagus. We could visualize a foreign body which was ovoid in shape. The scope was passed beyond the foreign body to see what is obstructing the foreign body from going down. We could see a proliferative growth in the mid esophagus at around 18 cm from the incisor tooth. On visualizing the foreign body in detail by inflating the air, we could see that the foreign body was mobile, not attached. It was pulsating along with the thoracic pulsation. The retrieval of the foreign body was planned to be done with a Rothnath. The Rothnath was advanced and maneuvered, opened and maneuvered around the foreign body, probably the mango seed. The Rothnath was maneuvered fully to cover it almost 270 degree, more than 3/4 of the foreign body, and the catheter was advanced forward and the Rothnath was tightened and grasped. One important thing while doing this is that the wheel should be adjusted so that the foreign body is tightly grasped, and suction should be given to clear the vision, and with suction the Rothnath, foreign body and the endoscope should be pulled outside. If the foreign body is too large, we may not be able to take it along with a Rothnath. In that case, a snare should be used. After taking the lesion out, the foreign body outside, we could examine and find that that was a mango seed which was impacted in the mid esophagus of this elderly lady. A redo endoscopy was done to see in detail about the esophageal lesion. We could find a proliferative lesion extending from around 18 cm from the incisor tooth level. We visualized to see if we could manipulate beyond the lesion to know the extent of the lesion. The lumen is being narrowed with proximal esophageal dilatation. The proliferative lesion is found to extend into the lumen. Slow manipulation is done, and we are attempting to enter beyond the lesion to see the extent and to see how the esophagus, stomach, OG junction and other anatomy beyond it is. Slow manipulation is done and the scope is passed beyond the lesion into the esophagus beyond the lesion, and we could find that the lesion was extending up to 25 cm from the incisor tooth, and the esophagus beyond that was normal. OG junction is normal. The stomach, the body, the antrum appears to be normal. The pylorus of the stomach is also normal. And entering the D1, we could see that the D1 is normal, the D2 is also, the D1 is normal, and the D2 of the duodenum, second part of duodenum, is also normal. On retroflexion, we can see that the fundus and the OG junction is free of the disease. So this was a mid-esophageal lesion from which biopsy was taken, and biopsy is being sent to see the pathology of the lesion. Probably it could be a squamous cell carcinoma or an adenocarcinoma, and the further treatment depends upon the pathological diagnosis of the patient. Patient improved symptomatically. She was started on oral clear liquid diet, and she was advised to undergo further evaluation for the staging of the malignancy with follow-up with the biopsy reports to decide on the further treatment plans of the patient. Thank you. As a rule, any patient who presents with an foreign body impaction in the esophagus, we must never consider it normal, but work up for causes like neuromotility disorders like achalasia cardia, DES, strictures, benign or malignant, post-RT strictures, long-term use of NG tube which would have caused narrowing and strictures and ulcerations, malignancies, esophageal ulcers, malignancies like squamous cell carcinoma or adenocarcinoma, If everything appears to be normal in the esophagus on endoscopy, we must think about eosinophilic esophagitis and take biopsies to rule out eosinophilic esophagitis. In elderly people who are mentally retarded, per se can cause hypermotility of the esophagus and esophageal food obstruction or esophageal foreign body obstruction. Many times patients may come with even food bolus obstruction. So as a rule, if patients comes with esophageal obstruction causing symptoms, it should be intervened endoscopically urgently.